There is a skill that separates the emergency physicians who navigate complex clinical situations effectively from those who struggle through them. It is not intubation, it is not ultrasound, it is not resuscitation technique. It is high stakes communication, the ability to communicate precisely and effectively with consultants, with patients receiving bad news, with families in crisis, and with administration. Most residency programs teach diagnosis, procedures, and clinical reasoning. They do not systematically teach clinical communication under pressure, and that is the skill residents learn too late. Residency training is structured around clinical knowledge and technical skill. You learn to interpret ECGs, manage airways, recognize sepsis, treat myocardial infarction. These are foundational skills. They are necessary. But the outcomes you produce as an emergency physician depend as much on your ability to communicate as on your clinical knowledge. A missed consultation because your handoff was unclear creates the same risk as a missed diagnosis. A poorly delivered critical disclosure traumatizes families in ways that reverberate for years. An ineffectively framed safety concern to administration means the problem persists until someone gets hurt. The physician who communicates precisely and effectively in all four contexts, consultants, patients, families, administration, outperforms the one who cannot, regardless of technical skill. And most physicians learn this through failure rather than through deliberate training. Most consultation failures begin with a poor verbal handoff. The receiving consultant is working from incomplete data, unclear expectations, or without understanding your level of concern. The result, delayed care, inappropriate disposition, or consultant frustration that damages the working relationship. The SBAR framework solves this: situation, background, assessment, recommendation. Use it as your minimum standard for every verbal consultation. Situation: what is happening right now? 62-year-old male, chest pain, hypotensive to 85 systolic. Background: what led to this point? 2 hours of substernal pressure, no relief with nitroglycerin, troponin elevated at 0.8. Assessment: what you think is happening. Concern for acute coronary syndrome with cardiogenic shock. Recommendation: what you need from the consultant. Request immediate cardiology evaluation for possible catheterization, and state your specific question explicitly. Not, can you see this patient, but does this patient require operative intervention tonight, or can this be managed non-operatively with next-day follow-up? The consultant who understands exactly what you need is the consultant who can give you a useful answer. There is no comfortable way to deliver news of a death or a critical diagnosis. There is only a competent one. Sit down. Sitting signals that you are not rushed, that this conversation has your full attention. Make eye contact. Speak in plain language. Do not soften the truth to the point of obscuring it. Your husband has died is clearer and kinder than we did everything we could, but unfortunately his heart stopped responding to our interventions. The patient and family need to understand what has happened. Their ability to process and grieve depends on clarity. Euphemism interferes with comprehension and delays the grief process. And after you deliver the news, hold silence. Do not fill it. Silence after disclosure is not awkward. It is appropriate. The family is processing. Give them space to do so. When they are ready to ask questions, they will. Administrative communication is a clinical skill. How you frame concerns determines whether they are heard and acted upon. Lead with data, not emotion. I am frustrated with the boarding situation is heard as complaining. On 3 of the last 5 shifts, census exceeded safe staffing capacity by 40%, and we had 2 delayed diagnoses attributable to incomplete evaluations during surge. Is heard as a patient safety issue that requires intervention. Propose a solution alongside the problem. Administrators respond to physicians who diagnose and treat, not just complain. We need more nurses is vague. Adding 1 nurse to the 3 to 11 shift would reduce median door-to-provider time by 15 minutes based on our current census patterns as actionable. And when the safety stakes are high, document your concerns in writing. A verbal concern with no record cannot be followed up. Email creates accountability. Use it. When the department is at capacity and wait times are long, the communication that prevents escalation is brief, honest, and specific. Do not promise a timeline you cannot guarantee. You'll be seen in 20 minutes becomes a lie when the trauma rolls in and consumes your next hour. Instead, promise what you can deliver. You are being monitored continuously. I will return with your test results as soon as they are available, and I will update you if anything changes. Patients who understand what is happening and why tolerate wait times significantly better than patients who feel ignored. Brief updates, even when the update is, No new information yet, but you remain on my list and I am tracking your workup. Reduce complaints and prevent escalations. Presence and honesty are more valuable than false reassurance. Patients know when they are being managed versus respected. Respect their intelligence. Communicate clearly. They will tolerate uncertainty better than they will tolerate dishonesty. 4 things. First, treat communication as a clinical skill that requires deliberate practice. Seek feedback on your consultations and disclosures. Ask your consultants, was that handoff clear? Ask your colleagues, how do I communicate in high pressure situations? The feedback is data. Use it. Second, use SBAR as your baseline for every verbal consultation. 30 seconds of structure reduces consultation failure significantly. Make it automatic. Third, when you must deliver difficult news, a death, a terminal diagnosis, a devastating complication, do it in person, sitting down in plain language with time held for silence. That is the competent standard. Fourth, when communicating with administration about safety concerns, lead with data and propose solutions. Document in writing when stakes are high. The physician who communicates well is safer, more effective, and more trusted. In every direction, communication flows. This is Global MedOps Command, Clinical Brief Series. High-stakes communication is not a soft skill. It is a clinical skill that directly affects patient outcomes. Learn it deliberately, practice it systematically, teach it explicitly. Next brief, what appropriate transfer actually means in practice. Stay prepared, stay educated, out.